Hi, this is Dr. Hagop Kantarjian, and I welcome you to the last session at SOHO, which addresses the next questions in the hematologic malignancies. So what you'll hear is a summary of the most important breakthroughs and future trends in hematologic malignancies. And we're going to start with the next questions in acute lymphocytic leukemia by Dr. Bilal Shah.
Hi, my name is Bijal Shah from the Moffitt Cancer Center. Thanks for inviting me to speak on next questions in acute lymphoblastic leukemia. I think one of the themes to evolve from this year's meeting is who is high risk, or what is high risk ALL in 2021? Certainly we saw from Dr. Lori Muffley's presentation an extension of data developed by Dr. Berry and colleagues in their meta-analysis looking at MRD. Those patients who are MRD positive, whether it be post-induction or post-consolidation, whether it be by NGS or by flow, those individuals seem to have an exceptionally poor outcome. We're also seeing now that those same tools can be used to anticipate outcomes in the context of bone marrow transplant, and that now peripheral blood assessments using these very sensitive NGS techniques may also be helpful in guiding prognostication and hopefully the integration of novel agents. We saw from Dr. Chiretti and colleague, we saw from Dr. Chiretti that outcomes in older adults with ALL are still quite poor, and this is data from the SEER index highlighting much the same, that as our patients get older, their tolerance for therapy decreases, but we also see at the same time a higher risk biology that complicates our delivery of chemotherapy. We also saw from Dr. Tichy that taking all of these things aside and just focusing on, hey, we've got relapse disease, where are we now? We can see here in B-ALL, we've had some improvement over the past several years in outcomes, in part due to agents like blinatumomab, inotuzumab, and CAR-T. But in T-cell ALL, we're still working to improve outcomes. And we can see here that for those that relapse with T-ALL, even amongst children, we're talking about 32% longevity. What about Philadelphia chromosome positive disease? Is that still high risk? And Dr. Parto Kebriai gave a wonderful talk on this particular condition. This is my reflection on the evolution of data in Philadelphia positive ALL. Beginning with hyper-CVAD and imatinib, we could see a median event-free survival of around 22 months. Moving into the dasatinib era, broader TKI, we can see here that we're significantly improving our 3-year event-free survival, not yet even reaching that median endpoint, but coupled to a very high rate of allogeneic stem cell transplant. Moving into the modern era with the introduction of ponatinib onto frontline regimens, we can see here now the 3-year event-free survival is even higher, estimated at 76%, but with a lower allogeneic stem cell transplant rate here at only 20%. Begging the question in 2021, is Philadelphia chromosome positive disease still considered a high-risk entity? So once we've recognized who's high risk, what do we do about it? What is the optimal approach? And we saw a few lectures as part of this meeting discussing toxicity mitigation so that we can improve our ability to deliver the drugs we want, the integration of novel agents, and what I hope is the future, that is replacing some of our standard chemotherapy approaches with these novel agents. Reflecting on the data that Ibrahim Aldas had presented, you can see here that we're moving away now from simply managing the toxicity to trying to find novel ways to prevent it. And you can see here that can include hydrocortisone and histamine administration to avoid hypersensitivity. There may also be a role for rituximab, as we saw from the New England Journal paper, the GRAL data, where the incidence of hypersensitivity was lower in those individuals who had received rituximab as part of their asparaginase-containing regimen. We may be able to move towards carnitine prophylaxis rather than just management. And this is internal data from Moffitt that that we had generated some years back, showing that we could significantly reduce our rates of grade 3 hyperbilirubinemia and grade 3 and above, AST and ALT elevations by prophylactically building this into our therapy when we're delivering asparaginase. We can also speak to thrombosis and the role of anticoagulation and so on. Can we use biology to guide the incorporation of targeted agents into frontline chemoimmunotherapy? And this was, something that Dr. Chichi had presented in his data. And I think the answer is yes. I think that we can start to disentangle some of these mutations, just as we have done in Philadelphia chromosome positive ALL, to try and understand how to optimally integrate, novel agents. We're getting a hint of this from data using BCL2 inhibitors as a component of relapse refractory therapy. And so this is data that Wendy Stock and her colleagues from the University of Chicago had developed, published recently in Cancer Discovery. And a lot of data here. I think the thing to really notice here is when we focus though on remissions, right? We have all these different subtypes of B-ALL and T-ALL, but I want you to focus at the bottom part of the left-hand figure at the early T precursor ALL subgroup. And here, this biology seems to identify an enhanced likelihood of responding to this combination of navitoclax, a BCL-XL inhibitor, and venetoclax, the classic BCL2 inhibitor. And that seems to be the case even in those individuals that have high MCL1 gene expression. Again, suggesting that biology may help to drive some of our novel agent incorporation when we talk about the management of ALL. I hope we can go farther, and I hope we can begin to start to develop, really at the bedside, rapid, informative tools to guide what we do in ALL, be it in newly diagnosed or be it in the relapse setting. And so this is data I had shared at SOHO a few years back using, a tool that we developed here. We call it EMMA, where we layer patients' tumor cells on stroma, with their own plasma and so forth, and then ask specific questions about drug activity. Using live image capture, we're able to get a readout in about 5 days to give us a general sense. The hope then is to be able to feed this forward right onto those mutations that we're identifying with some of our comprehensive assessments. I also want to bring in, some of the data that Dr. Bornhauser presented, and this is data that their group had published in Blood a few years back. This is the PDX modeling, but they had also done something very similar using in vitro methods to try and figure out what are the best tools. And you can see here across all these different drugs, really trying to highlight, hey, what's likely to work, and now building this backwards to some degree to say, what is the biology where we can expect more activity? What about MRD? So we have this wonderful data from Dr. Muffley, but we also have data that was presented here looking at the role of blinatumomab, specifically blinatumomab, in the setting of minimal residual disease. And this is the data from Nicola Gokuje and their group showing that blinatumomab followed by allogeneic transplant can be a highly effective method for getting patients back into remission. And again, these are individuals who are technically in their first and second complete remission, but still have that persistent MRD, who are now moving forward onto this therapeutic approach. But it is not just blinatumomab. We're seeing similar data emerge out of the CAR T-cell immunotherapy space. And so this is data from Laura Schultz and colleagues looking at the efficacy of CD19-based CAR T-cell immunotherapy. This is Tisagen Laclusil in pediatric patients. And what we see here is our event-free survival and overall survival increase as we move from high disease burden to low disease burden settings. This is less than 5% blast without extramedullary disease or even undetectable disease now. So now we're no longer able to detect the disease, but we know that they we used a salvage of some sort to sort of take them to the CAR T, and this is that pre-CAR T assessment. And those individuals who cleared their disease now undetectable really have an outstanding, 1-year overall survival and event-free survival, particularly for having high-risk relapse disease. So with all these, introductions of novel agents, are we ready now to dose reduce? And I hope the answer is yes. And this is data, from the MD Anderson group looking at the mini hyper-CVAD protocol. So now we've taken out the anthracycline, we've dose reduced the Cytoxan, dose reduced the cytarabine and methotrexate, but we built in some novel components, inotuzumab into the chemo component, and then as a Blina consolidation following that. And you can see here in elderly patients, really outstanding outcomes. And the data, again, are also looking very promising in younger patients with newly diagnosed ALL. Can we move to a point where we totally eliminate the chemo? And I think that, is data that Dr. Wiedewald spoke to earlier, and we're as we explore combinations of inotuzumab and blinatumomab in newly diagnosed elderly adults, we actually have a model that's evolving in what we used to think of as high-risk disease, the Philadelphia chromosome positive space. And so you see here this combination of blinatumomab and ponatinib in newly diagnosed adults with ALL, showing really outstanding 1-year overall survival rates of 93%. We're starting to see this also built into, our paradigm for treating children with ALL. And so this is the AALL171, the 1731 protocol that was shared with us at this meeting, showing that with the introduction of blinatumomab, it's hoped that we can begin to dose reduce some of our chemotherapy, again, taking out the anthracycline from induction and cutting back on some of the intensifications, in this case, taking out one of our blocks of intensification, in this case for patients with Down syndrome ALL. How do we manage relapse? So now we've used inotuzumab, we've used blinatumomab. Where do we go from here? This is data from the ZUMA-3 trial, and you can see here that we're showing, I think very meaningful overall survival, 18.2 months measured here, not reached in those who have complete remissions or complete remissions with incomplete count recovery. And importantly, as depicted in the figure on the right, our response rates do appear to be preserved in spite of prior transplant, in spite of prior blin, in spite of prior inotuzumab, suggesting that this agent really does have some sticking power. What about alternative CAR T cell constructs? This is data that Dr. Liu had presented, again, looking at their STAR CAR T cells. So now trying to build a chimeric antigen receptor that has a little bit more of the T cell biology baked in, but with this variable heavy and variable light chain. You can also see their fast CAR T system, where now they're able to produce the CAR T cells in 1 day. And finally, we're starting to move towards donor-derived CAR T cell constructs. And this again is data that Dr. Chichi had shared and Dr. Liu had also alluded to, and showing that there may be some staying power here using a donor-derived CD7 CAR T in T cell ALL now, where we've been sorely lacking a CAR T cell product. With that, I want to thank you and thank all the incredible presenters whose data I tried to highlight for this presentation on next steps. I think there's a lot of exciting things coming, and really, I think it's just a great time to be an ALL investigator. But I think finally for our patients, we can start to deliver some really promising new therapies that have the potential to deliver a cure with less intensity.